we've recently had a patient with Waldenstrom's macroglobulinemia. And with that person developed large cell lymphoma, was able to get CAR T. Also, the most in the newest indication is chronic lymphocytic leukemia, and lisocabtagene has that approval. Managing and generating a CAR T from CLL is a little difficult because your blood is often maybe contaminated with the CLL cells. So it does require a special manufacturer. What's coming? We think potentially as early as next month, obicabtagene autoleucel will be a new CAR T that we think will get FDA approval for relapsed refractory adult ALL. It's got a very unique biology. We currently have brexucabtagene or Tecartus approved for that indication, but this particular one has a fractionated administration where you give a little dose first based on your marrow burden, and then 7 days later you give a second dose. But it's really unique that they have, and I'll talk about the, how a CAR T sees its target, but as opposed to binding to a target cell and staying attached for 15 minutes before it drops off, it's a fast on, fast off. The CAR T binds the target cancer, hits it, delivers a message, and it's off within a minute. Actually, it's less than 30 seconds, if I remember correctly. And they think that this is going to be associated with far less toxicity like cytokine release syndrome or ICANS. We also have non-CAR T immune effector cell therapy approved. Most recently, afamirestigene autoleucel is for treatment of relapse refractory synovial cell sarcoma. This is where they'll take autologous product and they will insert genetically a T cell receptor that's specific for HLA-A2 peptide presenting of a MAGE-A4 peptide, and that's been shown to have approval, and it's working. And then we have lifileucel, which is for BRAF resistant or BRAF wild type or checkpoint resistant inhibitor resistant metastatic melanoma. And I'll talk about that. That was approved in February of 2024. The MAGE-A4 was approved in August, and we think obicabtagene will be approved in November. Briefly, there are now, if you look at all cell and gene therapies in the United States, there are now about a little less than 40 that have been approved, a number of them for skin conditions, including cord blood. We have 8 cord blood banks, but cord blood has to be registered, so they count in that 40. So the actual number of what we think is novel gene and cell therapy products is still pretty small, except now we're anticipating, the country is anticipating over 10 new products will be approved annually. And we're going to continue to see this. And importantly, it's not, if you look on the right, it's not going to all just be cancer. It's going to be a host of other disease. We already have hemophilia approved, beta thalassemia is approved, sickle cell is approved. We have a series of neurodegenerative that's approved for gene therapies, but it's going to increase. And then I took this is a slide I have from someone in the past, which is in the United States, if you look at the number of potential patients with a disease that is sensitive to a gene therapy or a CAR T therapy, immune effector cell, based on 50 million lives, you can see that leukemia and lymphoma is 23,000 people, except that's based on 50 million lives. Our US population is almost 350 million, so the potential, you have to multiply that by 7. So the potential patients who are eligible in the United States over the next decade on an every year basis could be 200,000 patients. Now, in the very bottom, what you're missing, it looks like it's blocked from being shown. Does it get it bigger? Sorry, no, it doesn't make bigger. Anyways, I looked at the population of Thailand, Laos, and Cambodia together makes almost 100 million people. The life expectancy in Thailand is 76 years. Laos reported this would be UN data or WHO data. The life expectancy in Laos, 68. Cambodia is age 71. So they're all sort of in that similar version, knowing that cancer goes over age 60. these numbers actually would translate very well to the Southeast Asia, that if there was available ability to deliver the treatment, there'd be many, many recipients potentially. So what is a CAR T? Start with, first of all, it's a T lymphocyte. We all have, as part of our immune system, we have T lymphocytes. Importantly, as opposed to like the MAGE peptide, which is very specific, a CAR T targets a tumor-associated antigen. A tumor-associated antigen is not a unique, every cancer could have its own unique footprint. This is not a unique cancer footprint. This recognizes a whole host of different cancers. And, so like CD19 is on all lymphoma. It's a tumor-associated antigen, but it also doesn't necessarily mean it's a unique antigen. So one of the side effects of CAR T, when you use a CAR T that sees CD19, is it kills off healthy cells that express CD19. It's you always have to worry about a off-target effect when we do CAR T. So if you give a CAR T, you may treat the on-target is the cancer, the off-target may be healthy cells, and you always have to be aware of what could happen. There's a very famous clinical trial that was developed for another MAGE partner that was expressed on myeloma. It turned out the first two patients who were treated both died in 5 days. And what they died of is cardiac pump failure, because it turned out there was a cross-reactivity of the MAGE restricted peptide on a cardiac muscle molecule called titin. And the CARs, when you infused them, targeted the heart, and the heart basically melted. But they ultimately cloned and identified that titin, T-I-T-I-N, which is a cardiac muscle specific molecule, was an off-target effect. So the off-target has to be paid attention. It's important that the structure itself is going to go across the membrane and point out to the environment around, and that's what you're going to depend on. It's seeing, and what we have is internally, though, you have a binding site, you have to make sure it signals. So there's a very important internal machinery also. 4-1BB has been used, and that will actually enhance persistence of CAR T cells. The CD28, internal domain will actually promote expansion. So again, this is immune therapy. And so what happens is after we collect the cells, from a patient, it's like a leukapheresis. Someone comes in and they come off the street and we just collect lymphocytes. We take that bag of lymphocytes and send it off to the manufacturer. Now you may manufacture it yourself in your own laboratory, or you may send it out. But either way, the goal is to grow those cells, expand them, and to a point that you now have, not a rare cell, but you're delivering millions of cells at once. And a standard dose may be 100 million cells of CAR T cells that you're given, 1 × 10⁶ per kilogram. And when you do that, then you have to be ready to see how fast they work. Recognizing that when we do make a CAR T in the laboratory, when we infuse it, there's an expansion that happens in vivo. And it has been multiple times we've seen where patients can have a 5 log increase in a matter of 4 to 5 days. So we can see this growth logarithmic expansion that will happen in vivo, and that's what leads to the cure of the cancer. Here we go. So this is just a pictorial of the process, which just basically says that, in number 1 in the clinic, you collect the white cells. In the laboratory, you send it to the laboratory, your own lab, or you send it out. And typically, we're using viral vectors to get the new gene in, the construct. It's a fusion construct with an antibody and a activation domain of a T cell. But you are now moving into other non-viral vectors, doing electroporation, CRISPR technology, a variety of ways to express it. Then once you think that you've got the viral, you've had enough time for the integration to take place, you have to have time for expand the cells to get enough to then transfer ex vivo back into the patient. Interestingly, some of the newest research right now that's happening is there are companies, there's at least 10 companies based on laboratory experience. They've now made a viral vector that carries the CAR T construct. And what you'll do is you'll infect a patient directly with the virus. So the just does not get expanded in the laboratory. You let the virus go through your bloodstream. It will bind to the T cells. It will integrate in the T cells, but it will be on an inducible promoter. So maybe 7 days after you give the virus, you'll come in and say, take tetracycline. So typically a tetracycline's a inducible promoter. Someone takes tetracycline, you turn on the virus, it's incorporated into the T cells, and so you create in vivo generation of your CAR T. That may be coming as a future. The CAR T structure is very simple. We have an antibody domain. We all know what an antibody, or we think most of us know an antibody looks like. It's got a particular binding domain. When they cut the binding domain out, that will see an idiotype, and it sees a particular target antigen. It's a peptide antigen. Now, they've created a structure that a lot of people say, well, that's the most important part, is what we call the scFv. Well, now we're finding that all these other parts make a difference too. The hinge region is really critical. The hinge is, depending on how you target it, it could be very close to the membrane or it could be very far out from the membrane. And that length of the hinge actually could impact the complications in the rate of growth of the CARs, because it will actually regulate the CAR expansion. We have the transmembrane domain, which, again, we just figured all we need is a hydrophobic anchor. Well, it turns out that may be important for sterically how you deliver the signal from when you bind with your scFv internally. Now, inside the cell, there's some important areas. One is the co-stimulatory domain, which is what partly activates the T cell. But what a lot of people, and you'll see, you need this major signaling component, which is the CD3 zeta, and that will activate downstream. Somewhere in about 30 minutes, you'll see what co-stimulatory domain and the main signaling domain, how you can use that, just that knowledge, to make interesting new molecules. So I'll skip this one. Says the same. So where are we today in immune effector cells? Some of you may have seen me present this last year. In the middle, this is a slide from Wells Fargo. They have an investment firm that keeps track of what's happening in cell therapy. In the very middle are the current FDA-approved products. These are what's marketed, and there's a half a dozen. But if you look at in the concentric ovals around it, it's all of the potential future cell therapies that are in development. It could be an autologous CARs, like all the way on the right. You could be doing T cell receptors being cloned to expressed on the left is the autologous CAR, on the right is the T cell receptors, on the bottom is natural killer cells and dendritic cells and macrophages. There's a whole lot of CAR cell therapy products that are now in the process of being developed. Every one of those may fail, but also every one of them may be successful and may become a standard drug that the pharmacist has to be excited because they have a whole new long list of names that they're going to have to know and manage. I want to say that what we've done, you can see, I've been involved with CARs since the development of the research side in 2012. So 2018 is when we first started doing, this is our commercial CAR Ts. And, we started to grow 17 and 18 in 2018, then 18 in 2019, 2020 went to 27. We actually thought with COVID, we would slow down in transplant. Our numbers are transplanters on the left. In COVID, we actually slowed down with COVID. But it turned out we felt that CARs are being given in almost emergency circumstances sometimes with high-grade lymphoma. We didn't slow it down, and we've had a continually expanding CAR T activity that this particular year we're on target to perform 110 procedures. So when I said there's little interesting science that's coming out, well, when a T cell receptor sees its target HLA molecule that expresses peptide. It's a loose interaction. It's a low affinity interaction. It binds. It says, is this something I want to stick to? And sometimes it will barely touch it and it will bounce off because it wasn't tight enough. Sometimes it'll activate it. But then once the T cell receptor says, I like what I see, it sends a series of intracellular signals through those inside the membrane areas and brings new molecules to the area, and including adhesion molecules. And so you have a T cell receptor C and HLA. It says, I like what I see, sends a signal, and it brings adhesion molecules together, and it builds this ring structure around it. And that one does two things. It strengthens the T cell receptor binding, and it also sends a signal back to the T cell receptor, you got to kill this. This really needs to be hit. So we call that the immunologic synapse. We talk about the synapse is where the nerve meets its target and then at the end of the axon, at the nerve terminal. Well, we're now calling this the immunologic synapse, and people have studied the immunologic synapse for years. And what it will do is bring my molecules, they will migrate in the lipid bipolar membrane to the site, and they'll create this really well-defined structure that actually on activation will then signal the T cell to send in and degranulate particles from the lysozymes to kill the cell. Now the CAR turns out to do something different. There's so many molecules, and it's a very high affinity receptor based on the antibody. But when it binds, it clusters. It sees its target and it starts to activate, but it just clusters. But the membrane is totally disrupted. It doesn't have this beautiful structure that the T cell receptor has. And it's really important. Why does that matter? This is a picture of what we think the immunologic synapse is. On the left is what happens on a T cell. And on the right, you can see there's a T cell, nice, tight, interaction. And then on the right side is the CAR. The membrane is very loose, and it's creating it's not a tight junction. Now that is important for a couple of reasons, which is summarized here. I'm not going to review this all, but I'm going to tell you, this is from a review paper that was just on that last slide. The difference is a T cell receptor can see one molecule on a target cell, and that would be high enough activation to say it'll set a cascade that will kill the cell. Most people think that one is very low. It's probably closer to 50 molecules per cell. CAR T, though, because of this loose clustering, it needs about 5,000 molecules per cell. So it's been shown in the case of ALL, this is the work from Crystal Mackel at Stanford. With ALL, CD19 works well because it's high expressed. CD22 turns out to have variable density. And in low antigen density, the CAR T may not be able to kill the cell because you just don't have enough molecules that can cause the clustering and allow the signaling. So that's a major difference between the CAR T and a T cell using its known native endogenous receptor. There's a variety of aspects of how signaling occurs. There's a separate set of signaling pathways. But I think the thing that I like, or I think is interesting, is, as I said, the immunologic synapse is loose. And when you have this clustered, activity with a CAR T, you can induce an activity called trogocytosis. Now, what trogocytosis is, again, Dr. Zurpol asked me to give good science. This is one of the newest things. When you develop a cell and try to kill a cell, when the cell-cell interaction happens, the target cell can transfer molecules back to the effector cell. And so with trogocytosis is now we're seeing is that the CD19 on a lymphoma cell, the CAR T binds to it, you're actually transferring back CD19 molecules onto the surface of the CAR cell. And so you can now have CAR cells killing themselves. And it's definitely been shown that what we call fratricide, that CAR Ts can sometimes, one of the limiting factors in the efficacy of CAR Ts is the entity of trogocytosis. So it's an interesting issue, but again, it's so when you talk about T cells in cars, yeah, it's you're putting the car into a T cell, but you're not using the native receptor. You've created a whole new biology of cell signaling and how you deliver the kill. So I say that CAR T is a saga of success and failure. You know, yes, we have changed the natural history of many diseases. We are curing lymphoma that wouldn't have been cured before. But we also know that we haven't cured everybody. So there's room for improvement. And then, you know, and I point out that when you pick a CAR, if you pick a CD28 CAR, you're going to pick a CAR that's designed for fast proliferation and growth. But like if you look at axicabtagene, which is the classic CD28 approved CAR, if you look for persistence at 2 years, there's almost no detectable CARs. If you use a 4-1BB, it doesn't have a fast proliferation, but it's designed for persistence. And you can have long-term, you know, identification of the CAR in circulation. And of course, what we have is these issues of, you know, why do patients relapse when we give a good T cell product? Well, there's a variety of issues of why CARs are not 100% effective. So I only throw this slide in for one reason, not because I want to look at all on the right, but this was the first, on the right side is the paper from Nature Medicine, the first 2 patients treated in the United States at the University of Pennsylvania. They had chronic lymphocytic leukemia, and the CARs cleared out the CLL, out of the bone marrow. But on the left, I put in yellow, they went back and they published in 2022 a paper where they went back to those first 2 patients. It was 10 years after they were treated with CAR. One, they're alive. These patients had very advanced CLL. There's no way they would have been alive, but they drew blood from them. And they were able to isolate and find CARs in the bloodstream, grow them in the laboratory and expand them in the laboratory, and then test them and show that they were still immunologically viable. They were still eradicating CD19 positive cells. And those 2 individuals that also required long-term immune globulin because they didn't have the capability of making their own IVIG. So this is one of our first patients that we treated with CAR T that, you know, when we first started this, you know, the first couple of patients didn't do well. And we said, we don't know we believe in this. Is this really going to work? But then I had this gentleman who has on the left, this was his baseline when he came to us. He had refractory large cell lymphoma. And on the right that's day 29. That's a PET scan. And he was in complete metabolic remission, you know, at the end of, 4 weeks. And when you calculate his tumor burden, he probably had 2 kilo, you know, 1 kilo to 2 kilos worth of lymphoma. And that all disappeared, you know, and interestingly, he only had very mild cytokine release syndrome. So you can get these dramatic responses without toxicity. Historically, this paper's been, you know, quoted a lot. What happens to patients who have lymphoma and you take them on auto transplant and they're now in 3rd line? You know, what's the likelihood of them staying alive long term? And this Scholar One retrospective study comes out of a product of the Coral trial from Europe, which was a randomized trial of transplant with or without Rituxan, with or without a bunch of other things, but also the MD Anderson database. And what they showed is you would expect at best, at 2 years, you know, a 15% survival and only 7% of patients in complete remission. Those were the numbers if you look at the Scholar retrospective. It is retrospective. However, the FDA accepted the Scholar data to make comparison. And so, you know, again, some of you may have heard in the past, I was the international scientific director of the scientific steering committee director for tisagenlecleucel. For Juliet, this is the Juliet trial for large cell lymphoma. And what we showed is if you take all comers, that 40% of patients would have long-term progression free. We are now writing up the 5-year experience. And at 5 years, we know that it continues to be a plateau. around 30%, and we cured 30% of patients who had at 5 years alive and well when it was only predicted to be, 7% in remission at 2 years, and none of those patients would be predicted to be alive. The upper curves say that if you are free of disease, though, at 3 months and 6 months, you could be predicted, though, to have now 70% long-term survival. So when we treat a CAR, we track what they do at 1 month, we track what they do at 3 months, but honestly, 6 months is the really important value. If you're at 6 months and you don't have a detectable disease, you've got an excellent chance of being alive long-term. That's what we did with tisagenlecleucel. The same data was seen with axicabtagene. This is ZUMA-1. And if you were, what the curves are, show that if you were CR or PR at, to the CAR T, you do well. You could see if you had stable disease only, like on day 30, it didn't look like you really got a significant response. All those patients, actually, this is progression-free, but all those patients had early death. And this is the same data from Transform, which is lisocabtagene. The curves look alike. I'm really not here to go over the individual trials, except to say that, like, even if you took the middle, the progression-free survival, you could see some patients fell off quickly. Those are patients who didn't have a disease, did not have an early disease response. But if you have a good deep PR or CR that can be sustained, your chance of staying alive and well without disease is excellent. These 3 trials were all approved for third-line large cell lymphoma. Well, now we have second-line CAR T because all 3 products were tested in second line. So someone has relapses, and the goal was to get them to transplant yesterday. At this session, we talked about some of these, this issue of second line, but lisocabtagene and axicabtagene, actually were demonstrated to have a very significant benefit to get patients into disease control. And they now have, if you have CAR T treated with primary chemotherapy and antibody, and you relapse within 12 months of the last dose of therapy, that meets the indication for second-line CAR. In those patients, we will do everything possible to get them to CAR. We really do not plan to do salvage chemotherapy. Sometimes we have to if the patient lives far away, but most of those patients, we rapidly try to get their cells collected. The most important thing is to get the patient to us and get the cells collected and send it off for manufacture. And then we can do whatever we want for bridging. We can do radiation, we can do chemotherapy, we can do steroids only. Bridging doesn't matter. Bridging is only to keep the disease stable. It's all about the CAR and getting the patient collected and manufactured as quick as possible is what's needed. I just did some work with a group of health policy people where we actually just published a research modeling showing that the improvement of survival is totally impacted by every 10 days. So if you can manufacture within 20 days versus 30, 40, 50, you will have significant difference in benefit. So we know that if we're going to treat with CAR T, there's a lot of things we've learned. There's a heck of a lot of things that will identify the patient who's going to do well or identify they're not, but also things that we need then to address. And this is just a summary of some of them, like which co-stimulatory domain product do you choose? How fast does it take to produce? What's the T cell? When you're ready to collect the T cells, how many T cells are in circulation? So we'll see absolute lymphocyte count. I had a patient once with its absolute lymphocyte count was, 250, that seemed low. It turned out he only had 60 CD3 cells. The rest of them were B cells, NK cells. And we just said, you don't have enough because we know that you're going to have a manufacturer failure. And we sent him home and said, just, let's try and suppress your disease. Like in the case we used polatuzumab and Rituxan, which they treated some of the lymphocytes, but shouldn't hurt his T cells. Gave him 3 months to build his T cell boost up, and then we were able to make the CAR T. So we have to pay attention to these little things. It's a list of them, but when you see them, the lymphocyte populations, that circulating CD3 count makes a difference between success and failure. And these are things that you learn over time. Um, and then how do we improve on it? Well, there's so much work to be done. As I said, we now know we can give a CAR. This is a schema that was, taken from a review article showing all the things you could do to modify and enhance the CAR T product. You can do double signaling, double targeting, add, checkpoint inhibitor to it. Every one of these little dots, though, is a clinical trial that's underway to improve the outcome of CAR T. We're going to do something right now. We had this discussion about plasma cell leukemia yesterday. And I have one of the things that we're doing for patients with very significant disease burden is we're going to take them to CAR T to reduce their disease. And then we plan to do an allogeneic transplant afterward. So we're going to do CAR T prior to allo because we think that's the right way to go. That is becoming standard right now for adult lymphoblastic leukemia, where there's some data from the real world experience show that in adult ALL, that if you look at CAR T for ALL versus CAR post immunotherapy after CAR T, if you do CAR T alone, the long-term benefit is not as successful as you do post-CAR intervention. And that could either be like adding a TKI if someone had pH positive or doing the transplant as new immune therapy. I'm not going to talk that much about CRS except to say cytokine release syndrome and the other side effects of CAR T, they're systemic. So the cells go everywhere, which means the side effects go everywhere. And so it is you can have multi-organ presentation, multi-organ failure. So the standard management, we have a whole host of standard approaches. Sometimes it's just as easy as putting someone on, they come in with CRS grade 1. There are some centers that give tocilizumab immediately for even the slightest amount of fever. We don't. We'll give someone 24 hours of scheduled acetaminophen, or plus sometimes we use twice daily Celebrex for an anti-inflammatory and say, let's see how you do. If they come in with 38.5, is a lot different if they come in at 40. If that first fever, that 40 degrees and higher centigrade, you're probably going to need tocilizumab. If that first fever is 38.3, 38.4, they may actually skirt the pathway. On the right-hand side is a figure. This is the CRS-free survival. I presented data at the European transplant meetings this April, where we ran a trial using itacitinib as a JAK1 inhibitor. They start the JAK1 inhibitor 3 days before the CARs go in, continue to day 26. And this figure, our patients, it was a randomized phase 2 for patients getting axicabtagene, Yescarta. And what we show is the likelihood of remaining without CRS was dramatically improved if you gave the JAK1 inhibitor for prophylaxis. There's going to be a lot of work coming out with prophylaxis coming forth. ICANS, what we find is really some people are using steroid prophylaxis. Almost have to use, if you use Toci alone for prophylaxis, you may have breakthrough ICANS. We found the most effective agent for us is we will use steroids up front. That's the standard induction. You treat with steroids. But we find that 24 hours, if we don't improve the neurologic toxicity, anakinra, the IL-1RA inhibitor, is very effective. Long term, you got to worry about hypogammaglobulinemia. And cytopenias is becoming one of those things that's annoying, that you've got to give transfusions, and maybe you can give them eltrombopag if they're aplastic at day 50. But there's now scoring systems that are coming out that will predict who has the blood toxicity. This is an interesting abstract. This paper just got accepted for publication. I'm part of this consortium, the cell therapy consortium. And what this was asking, currently the FDA says if someone gets CAR T, they have to come to our site and be monitored for 28 days. So we have people come from 200 miles away, 300 miles away. They have to relocate and stay with us for a month. This study was 8 centers. We're one of 8 centers that share all of our data. And what we showed is if you do not have, and this is where patients who had both tisagen, lifileucel, lisocabtagene, or Axicel, or axicabtagene. If you do not have detectable CRS or ICANS in 14 days, the likelihood of you ever developing it is almost negligible. And so what we just say is we just report this, but this may be the kind of thing that will change the FDA guidelines. It may change these things and make it better for patients to get home faster and need to have less. It also means less of my time taking care of someone who doesn't need care, and I can take care of someone who really needs care. Myeloma. Myeloma is our new disease. There's a lot of new, we talked also yesterday about how we approach myeloma. First line, second line, third line. Transplant still is the standard of care. As much as possible, I transplant everybody in first line. But what do you do when you relapse? Well, now you can take advantage of, in the past, we had other biologic therapies. Now we're looking at BCMA. For BCMA targeted therapy, there are immune conjugates, and the first immune conjugate was approved, has a lot of toxicity, has a epithelial toxicity. You have to do it with an eye doctor, an ophthalmologist, because they get a corneal visual issue. That was belantamab. That was pulled off the market because of toxicity. It's now being reintroduced with a different treatment schedule. The CAR T is what we'll talk about, and then there's bispecific antibodies. And everyone wants bispecific antibodies because, could you do the same? And you could do it in the community. You don't have to refer to a center. I'm going to show you what I think here. There's advantages and disadvantages. The CAR T cells, the conjugates do not cause CRS. They may cause a corneal toxicity. It requires some special management, but it's just a toxic, and I have a hard time getting that into patients. CAR T cells work beautifully, they work fast, but myeloma, they still recur. The bispecifics, what people are unaware of is that, or often are unaware of, they still can have CRS. And the way the guidelines are written is you have to put them in the hospital to do a dose escalation to get up your target dose. If you can get to the target dose without toxicity, then you could continue as an outpatient. But it is a continued long-term, treatment pathway. CAR T is 1 day only. The bispecifics is continual interaction. If you add up the cost of care of bispecifics, it's pretty expensive when you consider all those visits versus the very expensive single CAR. CARs do require a lymphodepleting therapy. We do not do a lymphodepleting therapy for bispecifics. So I'll point out that approved CARs, I mentioned this earlier, so we have our second line large cells. Now myeloma was originally approved with idacabtagene and ciltacabtagene. Ciltacabtagene they're both BCMA CARs. Ciltacabtagene is unique in that it has two binding sites. It's got a double scFv. So when it sees BCMA, it sees two different epitopes. Idacabtagene sees one. They were approved for fifth line therapy. Last April, the FDA in the United States now approved them for early application. And it can be as early as second and third line. I bring this up because, one, we're seeing CAR Ts move earlier in treatment, but there are issues about the delivery and the use of myeloma CAR T that you have to know. And click a button. So if we look at idacabtagene, this was basically a randomized trial. This is what led to the approval on April 4th, 2004, for it being used in early line. Basically, the CAR T was compared to standard regimens. The standard regimens were, could be, for instance, isatuximab with Revlimid and dexamethasone, daratumumab with bortezomib and dexamethasone, carfilzomib with dexamethasone. So a variety of well-defined second or third line regimens versus idacabtagene. And the objectives was to look for response. Well, what you see here is what the data showed. The difference in overall response was by 30% higher with CAR T. You could see the overall response was 71% for the patients with CAR T, and the patients getting standard, the overall response was 42%. And if you look at CR and stringent CR, we now have a 44% with CAR T and 5% with the standard. So again, a benefit of CAR T. And this is what it looks like for progression-free survival. There is a significant advantage over standard regimens. So CAR T is now approved. There was an important piece there that came out of that study, is if you look at ide-cel, and this is the idacaptogene, if patients had gotten either the bispecific antibody, but more of it was they got the immune conjugate. If they had pre-treatment with the BCMA product, there was a reduction of the response rate. So you could see the CR rate, went down from almost 50% to 30%. The response rate went from, in this case, it dropped down from if they didn't with prior was 75%, but overall response now goes up to 90%. And so and you could see that what impacts the bispecific definitely impacted. So we're aware of this. And so when I see a patient now, I want to use my CAR T before I use bispecific, because now these data suggest that pre-treatment may hurt, and maybe what happens is you lose antigen. There's also a second interpretation, which is the absolute worst patients were so desperate that I could not have time to make a CAR T, so I did the best therapy I had, and I gave them the immune conjugate, or I gave the bispecific. So I selected a patient population that was going to do badly anyways. And if I had done CAR T, they would have done badly. I'm saying, so there's two interpretations. One, that pre-treatment actually hurts your CAR T. Second, bad disease is bad disease, and that it would have done bad anyways. We don't know in the absence of a randomized trial, but we do have this single view that tells us that prior CAR T may hurt us. Cartitude, so siltacabtagene also had a randomized trial. I'm not going to go right to the point here. If you look at it, siltacabtagene also had a dramatic benefit over standard therapy. What's the difference between the last two trials? That trial, and this trial is in the one that tested idacaptogene, you have to have had failure of a CD38 antibody, a proteasome inhibitor, and an IMiD. In Cartitude-4, you had to be lenalidomide resistant. So if you did an autologous transplant and you had them on Revlimid maintenance, and they all of a sudden started to fail, you could go directly to CAR T. So it was a less treated population. And so it does look like that the data look great, but it looks like it may be better, but I'm not sure it's better because it's not a head-to-head comparison. So I think what happens is that you have it's a good drug. They're both good drugs. A lot of it is who's available to manufacture what you can make. And similarly, this is real world. The first look at real world presentation. This is last winter. Now I'm going to point out in the real world, we see the difference on the top line is cilta-cel. The bottom line was ide-cel. Looks like cilta-cel is better, but if you look at the total number of patients, it's 53 patients total in this abstract. Only 18 had gotten cilta-cel, 35 had gotten ide-cel. It really is, to me, there's no p-value because it's too soon, it's too small, but you'll see these curves in marketing, that this is the better drug. I can't tell you one's better than the other. I will tell you that cilta-cel has some very unique long-term complications. We could see Guillain-Barré, we could see cranial nerve palsy, and we have a patient who's now currently just died of this overwhelming neurotoxicity. And he had what it showed was not it looked like a Guillain-Barré, but he did not have a Guillain-Barré presentation. Looking by nerve conduction studies in EMG, he had complete peripheral nerve destruction and was basically had an ascending paralysis, had to be intubated to help him breathe because he no longer had the respiratory muscles to actually breathe on his own. He's basically since died of this neurotoxicity. the family did agree to a full autopsy. We'll know in about 3 months, what we learned. This says the same, skip that. So just saying that cars, oh boy, cars continue to be designed and new I was showing all those different trials. There's so much work going on in trying to make better supercars that will, potentially function better. Well, what I'm interested in is there's also some interesting products are being generated. This is a product we also collaborated on. It's BCMA. It's a fragment of the myeloma SCFE. And so you could see that on the model on the right, I put a star. There's a classic T cell receptor seeing its antigen. Here's an SCFE. Here's the bivalent, SCFE of cilta-cel. This sees myeloma, but it's basically they call it a double domain, where they just basically clipped the specific idiotype. So they got rid of much of the SCFE, the whole binding site, and it's a fragment, but it's got a high specificity for BCMA. Well, we've been part of the study. This is going to be presented. The final study is going to be presented at ASH 2024. Here's data from May of 2022. You can see all the forward arrows. There are patients with progressive disease, but many patients are gaining very long-term benefit. It does seem to have the same median progression-free survival of over 2 years as cilta-cel. There's not been any of the very late neurotoxicity that we see with cilta-cel in this compound. This compound has been made by a small company called Arcellx. Well, Arcellx has pretty much just been bought by Kite, which they own Axicell. And this is going to become a Kite product if it gets approved. And they are going for registration. And so you could see here in the patients at the time, 100% response rate, 70% complete remission. And if you're in 12-month follow-up, we have still 80% of patients with clinical remission using this unique molecule. Melanoma, just to talk into a new indication. Here's a patient with melanoma who got TILs. 1 month after the cells went in, really had this is like the best picture you always want to show, that here's what you want to have happen. The melanoma responded. So TILs are tumor-infiltrating lymphocytes. They are not genetically constructed. The T cell receptors, high affinity, it brings those T cells with the most highest avidity toward a tumor antigen to the tumor, but there's so much tumor around it, you induce tolerance, either T cell exhaustion or tolerance. And the T cells have the best possible receptor, except there's too much disease. So what you do is you cut out the tumor, you fragment it into little bits, and you isolate and purify the T cells, and then you grow it ex vivo in the laboratory, and you reinfuse the T cells. The first publication for TILs showing a benefit was in New England Journal in 1985. It's now almost 40 years later that we finally have FDA approval. And so again, I just talked to you, what you have to do is find the right patient. You have to arrange, the logistics are a little tricky because you have to arrange a manufacture date with the company. You got to arrange a surgeon who you want to isolate the tumor. You have to isolate an OR time, and it has to be early so you can make sure you can get the material cut out, isolated on the Fed Express plane, to get to where it goes. So it's a little bit more complex logistics, but they'll make the TILs. Takes a little longer to make, about 5 weeks. So you also have to keep the patient with metastatic melanoma alive to infuse the T cells. You give the T cells, they're not like the CAR, which will proliferate like crazy. It's this normal T cell receptor. So you have to use supplemental IL-2 to keep them healthy, as well as the same, really a more aggressive lymphodepleting chemotherapy. This is from one of the original papers where, that led to the approval of lifileucel. On the left was someone's cutaneous melanoma. And you could see over time the clinical response. And it took 4 months, but they did gain a clinical remission. And so what led to the FDA approval Well, these patients have a 36% response rate, CRs and PRs. So you got to remember, when we see a patient, 65% of patients are not going to are not going to benefit. It's an expensive product. I purchased it. My hospital purchased it with insurance coverage support for over $550,000. So it's over $500,000 just for the cells. And then we still have to pay for the cost of the care. The interleukin-2 costs another couple $100,000. It's $1 million per patient expense. But what we could say is, if you respond, if you're in the 1 out of 3 people who respond, it's very likely at a year and a half, you're going to continue without disease progression. And these are the data that show it. You can see on a waterfall plot, there's people on the left are the ones that grew. On the right are the patients that had benefit. You can see where we declare it. But the important thing is on the top is the overall, the duration of response was at 70% at almost 2 years. And the overall survival was about 30%. None of that was seen. That is better than anything else out there. Now, I would say personally, this isn't good enough. We're spending a heck of a lot of dollars for an insufficient result, but this is the first step. And lifileucel will not be the final step. And there's new TILs being developed, and new research trials where they're doing, during the culture conditioning, they're treating the patients so extra genetic manipulation. So you're like adding hypomethylating agents. They're doing things in the culture for post-translational modification of the TILs that will enhance the killing. So the FDA did grant on February 16th the approval, and it's now an effective product. So I think I have 4 minutes left from when I started. So I'll just say that for TILs, we do have a guideline. This was published a few months ago. If you decide to set it up, this is all the TIL centers got together and created a consensus management. It's a great document for how to do TIL therapy. And pretty much if you follow it, it's a recipe for success. I'm going to say this just to mention, though, that we, in the same way people are making constructs of CAR Ts, people are now making constructs of T-cell receptors to make a better T-cell receptor. I'm not going to talk about, I don't have time for this, but I think this is really cool. So what this group has done, and it was the work that came out of China, and it's now being run in clinical trials in the United States, is they created a CD19 antibody, and they identified the scFv that sees CD19. In the middle, what they did is they coupled it, though, to the gamma delta T-cell receptor. They got rid of the external binding domains of the gamma delta receptor, and they put the SC of CD19 on the gamma delta receptor. They also, it's proprietary. We don't know which co-stimulatory molecule they use. Could be CD41BB, it could be CD8, CD4. But what they did is they also coupled and created on a co-stimulatory molecule, they made a CD19 CAR. Importantly, intracellularly, they cut off the downstream signaling domain. So what this allows, the normal T-cell receptor, when it sees an antigen, it starts to bind and then it helps create the immunologic synapse. But you need that co-stimulatory. Their dual CD19 construct will now inform an immunologic synapse off of a CAR T construct, an scFv. And what they show is basically, I don't have time for this, they're now taking it to lymphoma in patients, and it's working. And what they're doing, seeing the big thing, the differences between this and CAR T, you can see objective responses is 80% CR and PR for very advanced lymphoma, is the risk of CRS and ICANS are dramatically lower because you're working through a T-cell receptor as opposed to a clustered CAR T population. New technology, new work. They have programs for CNS lymphoma and HIV lymphoma that we're working with, but also for hepatoma. They've developed this for hepatoma. And so we have a project going with them to look at the targeting hepatoma. Not all CAR T is a success. I'm going to say that AML has been a disaster. AML has managed to evade it people are planning CAR T just to cytoreduce and get someone to get someone to donor transplant. There's still been a lot of failure. A very exciting paper just got published in September, I think, from the group at Penn, from Carl June's group at Sar Gill's laboratory. What they noticed is they created a CD130 targeting CAR T for relapsed refractory AML, 20 patients, 8 of them died before they could make the CAR. But of those 12 patients, what they found is very high CRS, but very little long-term response. And they were saying, well, if CRS means the CAR is active, why isn't it working? Well, they went back in the laboratory. So this is a bed to bench and then back to bed. So they said they made the observation. It turns out that when you create CRS, there's a lot of cytokines. One of the cytokines that's generated is GM-CSF. And the GM-CSF so you're in the marrow, the CARs are in the marrow, the GM-CSF is being generated, but the GM-CSF is keeping the AML cell alive because the AML cell has a GM-CSF receptor. And then finally, so the AML won't die, the CAR T keeps trying to attack it, and finally the CAR T exhausts. So they say what's downstream from GM-CSF signaling is JAK. And so what they did is they did in the laboratory, they put ruxolitinib in, and up in the right-hand side, you can see, but just reintroducing ruxolitinib, on the right-hand side, there's the resistance of the AML with the DMSO, with Rux completely became sensitive. And so they're going to be taking a CAR T plus Rux pre-treatment to maybe see if they could change this in AML. And our folks that I've talked about, the gamma delta receptor, they're now developing a T-cell receptor. They developed SCFP to CWT1. Anyways, this ends right here. Autoimmune is the next horizon. I have just to talk about this, but you guys can read about it. They're now treating patients with autoimmune, and it's successful in eradicating disease or controlling disease. Will it cure it? We don't know. We currently are multiple trials going on in autoimmune disease, multiple sclerosis, myasthenia gravis, lupus, myositis, vasculitis, as well as CAR macrophages, NK cells, and TILs. We have a whole host of work going, and it's just been fun. That's the talk. So I was asked to give not a background that something everyone's heard, but hopefully show you what's coming as opposed to what you already know. I hope that worked.
Thank you.